So now I am switching over to group B. Are you ready, group B? So group B is represented by Sylhet, Northeast Medical College, right? Northeast Medical College. Thank you. So psoriasis at which site is the strongest predictor of the future development of psoriatic arthritis? Time over. Yes, scalp psoriasis. Okay. So group B, sorry for the technical fault. The first question to you is, which variant of spondyloarthritis is the most likely one to present with high grade fever? Very good. So 5 marks. Second question, which lung lobe may be predominantly affected in ankylosing spondylitis? 5 marks, correct. Which variant of spondyloarthritis is the most likely one to have concomitant painful oral ulcers?
Reactive arthritis.
Wrong. It's actually enteropathic spondyloarthritis. Reactive arthritis, the ulcers will be painless, usually. Painful aphthous ulcers. What is the postulated cause of Kodaikuna syndrome in patients with ankylosing spondylitis? Okay, the time is over. It's actually arachnoiditis. Non-infective arachnoiditis. Okay. So name any of the two IL-17 inhibitors approved for the treatment of axial spondyloarthritis. Anyone? Right. 5 marks. How many questions? Okay. The 7th question. What is the prevalence of spondyloarthritis in Bangladesh as per the most recent national survey that carried by WHO? No, I asked the national prevalence. It's a 1.2%. 0. The last question to you. Which vasculitis is the closest mimicker of spondyloarthritis? Very good. It's 5. They get 5. Okay. So now I'm going to group C. Are you ready? So group C, Sylhet Women's Medical College. What is the most common type of valvular heart disease in patients with ankylosing spondylitis?
Aortic regurgitation.
Very good. 5 marks. Group C. Name the two variants of spondyloarthritis where erythema nodosum may be found. You get 5 marks, 2.5 marks for each name. Yes.
Rheumatoid arthritis and
I asked spondyloarthritis actually. So this will be enteropathic spondyloarthritis and reactive arthritis, particularly due to Yersinia. Okay. 0. Name the two variants of spondyloarthritis where you are more likely to encounter thin, marginal, and symmetrical syndesmophytes. Two variants. Yeah. And another?
psoriatic arthritis.
Okay, you get 2.5 marks because this is ankylosing spondylitis and enteropathic spondyloarthritis. Okay. 2.5. How many questions did I ask? Okay. So what does ASDAS, AS stand for?
Ankylosing spondylitis disease activity score.
Very good, they got 5 marks. The fifth question. Which variant of spondyloarthritis is more likely than others to present with chronic bilateral and posterior uveitis?
Psoriatic arthritis.
They get 5 marks. Correct. Which anti-TNF is associated with the highest risk of infections? This is the sixth. Please name the interleukin 12-23 inhibitor approved for the treatment of psoriatic arthritis.
Ustekinumab.
Yeah, right. 5. They will get 5. The last question. Name 2 mimics of spondyloarthritis that may present with acne.
Sapo.
Right. And another? Okay. So they get 2.5 marks. There's Sapho and Behçet disease. Okay. So it was the last question for you. So now I am switching to Group D. So Group D, which area of the SI joint on an X-ray film is assessed for the radiographic grading of sacroiliitis? So it's anterior-inferior, 1/3 to 1/2. 0. Second question. Name the variant of glomerulonephritis most commonly associated with spondyloarthritis. So IgA nephritis. 0. What does DAPSA stand for? DAPSA. This is disease activity in psoriatic arthritis. Did you answer that? No. Okay. Which variant of spondyloarthritis is the most likely one to present with pyoderma gangrenosum?
Enteropathic.
Right. They get 5 then. Group D gets 5. So the next question. Which group of biologic DMARDs is preferred in patients with uveitis associated with spondyloarthritis? Sorry? Which group of biologics? Which biologics? Yes, correct. They get 5 marks. You should be a bit louder so that I can answer. I can hear. Sorry. Name the 2 variants of spondyloarthritis that usually present with asymmetrical sacroiliitis. Yes, 1. Okay, time over. It will take 2.5 marks. Which anti-TNF does not need to be withdrawn during the 3rd trimester of pregnancy? Yes, sartolizumab. So they get 0. Which MRI sequence is the most appropriate to detect both erosions and sclerosis affecting SI joints?
T1 inversion recovery.
Okay, it will be T1 sequence. STIR or short-term inversion recovery is for detecting bone marrow edema or sacroiliitis, active sacroiliitis. So they get 0. Which conventional synthetic DMARD used to treat peripheral spondyloarthritis is safe during pregnancy and lactation?
Sulfasalazine.
Right, they get 5 marks. Okay. So that was the 8th question, right? So this was the last question for you. So now group. Okay. So group. Okay. So the first round is over. So now the scorers will disclose the result of the first round. So I am now announcing the scores of different groups in the first round. Group A scored 20. Each question carried 5 marks for the correct answer. Group B scored also 20. Group C 25 and Group D 12.5. So the highest score was made by Group C, 25. So give a big hand for Group C. So now please get ready for the second round. So I'll start the second round now. The second round, as you know, will consist of scenario based questions. Each group will be asked 4 questions, and in this round, if any of the group fails to answer the question allocated for them, that same question will be referred to the next group in the alphabetical order, and afterwards, accordingly afterwards. So there is a chance of to score more for those particularly who are lagging behind, and there will be no negative marks. So I would like to request Group A again to get prepared for round 2. So Group A, are you ready? You will get 15 seconds to think and then answer. Start answering after I finish the question. Okay, thank you. So here you can see that a 20-year-old male present. A 20-year-old male. You can as the screen. This screen is it's not working due to technical errors. You can just rotate your chairs a bit so that you can see. We are seeing. So it's visible now. You can now turn your chairs and see comfortably. So is it okay now? Okay. A 20-year-old male presented with high-grade fever with severe low back pain for 1 week. And here you can see the MRI findings. You can see I am indicating with the arrows. These are the MRI findings. So my question is, what is the most likely diagnosis? You have 15 seconds. Think and then answer, please.
Reactive arthritis.
Wrong. So I'm stopping the timing here. So I am going to Group B. So 3 seconds over. Group C.
Osteomyelitis.
Wrong. Then Group D. Wrong. This is actually, you can see that there is soft tissue extension here. And there is high grade fever. Just a very short history. And this is septic arthritis. Okay. So 0. Next question, a 48-year-old, look at the age, the 48-year-old man presented with low back pain. So you can see the X-ray of the lumbosacral spine, AP and lateral views. The lesions, there are multiple lesions. There are several lesions have been marked or indicated with arrows, black arrows. So the question is, what do the arrows indicate? Timing starts.
Post-syndesmophytes, osteophytes.
Which one will you say? Is it osteophyte or is it syndesmophyte? You cannot say both.
Osteophytes.
Correct. So they get 5 marks. A 28-year-old woman presented with pain and swelling of the left ankle with a recently developed flat foot deformity. Ultrasonogram of the ankle revealed this is the condition of the left side and this is the right side. So right side is normal, left side is abnormal. So the question is, which tendon is affected in the image? You can answer it on the basis of the clinical scenario alone. The ultrasound image is just for your guidance.
Tendoachilles.
Wrong. Any?
Plantar.
No. Okay. Your chance is over. You can answer only once actually. So any other group B? No. No. This is a tendon. Plantar fascia is not a tendon. And group C? Group D? So this is tibialis posterior. Okay. Any problem in tibialis posterior may cause flat foot. Whatever it is, inflammatory, non-inflammatory. Okay. Then the fourth and last question for you, group A. A 28-year-old man with ankylosing spondylitis presented with inflammatory low back pain accompanied by recurrent episodes of acute anterior uveitis. Which will be the most appropriate class of DMARDs for this patient?
Methotrexate.
Wrong. Group B? Right. So they get 5 marks. Group B gets 5 marks, okay? Yeah, group B.
TMRs.
Yes, biologics are also actually DMARDs, yes. Okay. So now I'm going to group B. A 32-year-old male underwent MRI of SI joints for inflammatory low back pain. So you can see that the arrows are indicating some lesions here along the margins. So I am pointing it out along the margins. There are lesions on both sides. So timing starts. What is? Yeah, very good. So they get 5 marks. Group B, yeah. A 37-year-old man presented with inflammatory back pain. What do these arrows indicate? Wrong. Yes. Who said it? Romana Steinberg. Okay, correct. P 5 marks. So third question for you. A 20-year-old man presented with acute left knee and left ankle joint pain for 4 days. He has history of dysentery 2 weeks ago. He was found to have painless reddening of both eyes. What is the most likely ophthalmological diagnosis? Timing starts. Right. They get 5 marks. Group B. Yes, Group B gets 5 marks. Sir, conjunctivitis. Reactive arthritis. Conjunctivitis due to reactive arthritis. So this is the final question for you. A 40-year-old man with Crohn's disease presented with inflammatory low back pain. Which group of biologic DMARDs should preferably be avoided in this patient? Timing starts. Very good. So group B answered all of the questions correctly. 5 for this question. Okay. So well done, Group B. Then Group C. Going to Group C. A 36-year-old male underwent MRI of SI joints for inflammatory low back pain. What do the arrows indicate?
Arrows indicate bone marrow edema.
Here, the arrows.
Bone marrow edema.
The black lesions. I am pointing out the black lesions. So, any other group? Group D. Wrong. Then Group A. No, I have to be more specific. Everything is sacroiliitis. Then Group B. These are actually sclerosis. Black areas denote sclerosis. Okay. Then in MRI, the black areas actually indicate sclerosis. Then the next question for you. A 45-year-old expatriate from the Middle East presented with low-grade fever and inflammatory low back pain for 3 months. So this is the X-ray of the lumbar spine. These are the lesions, and I am interested in the arrow here. Lesion indicated by the arrow. You can see here. I am outlining this. Yeah. What is the most likely diagnosis just from this X-ray? Timing starts.
Brucellosis.
Very good. Brucellosis. They get so group C gets 5 marks. This is the classical parrot's beak sign found in spinal brucellosis, and this is the disc gas phenomenon. So both are found in the anterior aspect of the disc. Both are found in brucellosis. Well done. Then a 30-year-old man presented with redness of his right eye accompanied by mild discomfort and no ocular discharge. What is the most likely ophthalmologic diagnosis? This is the lesion.
It is scleritis.
Very good. They get 5 marks. The last question for you. A 43-year-old woman with psoriatic arthritis and MASLD, metabolic dysfunction associated steatotic liver disease. Now it is called as such, but previously it was called NAFLD, non-alcoholic fatty liver disease. So she has psoriatic arthritis and non-alcoholic fatty liver disease. She presented with predominantly peripheral arthritis. Name any of the 2 tumors that should preferably be avoided in this patient.
Methotrexate.
Thank you. So they get 5 marks for this. Another is leflunomide. As per the GRAPPA guideline, this should be avoided in NAFLD patients. Okay. So this was the final question for you. So now I am switching to group. Sir, I said any of the 2 tumors. Sir, just to make things easy for them, sir. So the first question for you. A 28-year-old male underwent MRI of SI joints for inflammatory low back pain. What do the arrows indicate? Wrong. Any other group? Group A. Group A.
Bilateral osteitis.
Yes, bilateral osteitis. Okay. Group B gets 5 marks. So actually, bone marrow edema, osteitis, almost synonymous. So I am osteitis is usually, this term is used when we use contrast enhanced T1-related fast accelerated sequence. But here we call it bone marrow edema, but still it's correct. I am giving you 5 marks for this. Okay. Then a 48-year-old man presented with low-grade fever and inflammatory low back pain. Can you please correct the screen? This is blinking too much. So you can see there the lesions. Here there are lesions and extending up to there. Okay. So what is the most likely diagnosis? I'm sorry for the technical problems here. Excuse me, this screen is showing nothing. Sir, blink করতেছে। Okay, so what does this? What do the lesions? Here the lesions. So what is the most likely clinical? What do you think clinically? What is the most likely diagnosis? I'm giving you 5 seconds more. 1, 2, 3. Right. So get 5 marks. So here there is spondylodiscitis, infective spondylodiscitis, and well-defined large paravertebral abscess forming a psoas abscess and also a psoas abscess. So this is nothing other than prosthesis unless proven otherwise. Then another question. A 30-year-old man with ankylosing spondylitis presented with progressive painless loss of vision. What is the most likely? Screen is okay now. The screen. What is the most likely ophthalmological diagnosis? Here I am indicating the lesions, these lesions here, and multiple areas are there around the blood vessel. So with an arrow, what is the most likely ophthalmological diagnosis? Painless loss of vision, progressive. Your time is over. Now going to group A. Wrong. Going to group B. Very good. Group B gets 5 marks. This is retinal vasculitis. Another just ophthalmological manifestation of spondyloarthritis. Okay. Then another question. A 43-year-old man presented with asymmetrical inflammatory oligoarthritis of lower limbs and inflammatory low back pain accompanied by chronic diarrhea. Biopsy of the terminal ileum after performing colonoscopy with ileocolonoscopy revealed foamy macrophages. So, what do you think is the most likely diagnosis? Wrong. So, group A.
Crohn's disease.
Wrong. Group B. Right. Group B gets full marks. 5 marks. Whipple's disease. This is Whipple's disease. This is a mimicker of spondyloarthritis. So, thank you all the groups for their active participation. So now I am going to announce the results of round 2 and then the final result. So the scorers, please hand the results over to me. So the scorers are taking, they'll take 1 more minute to, calculate the total marks obtained from group A and, round 1 and rounds 1 and 2, and then hand over the results to us. The result of group round 2 is already, done, but they are still calculating the total scores. So, dear audience, now comes the moments of suspense. So, now I am announcing the result of the second round first, and then I will announce the total scores uh, of rounds 1 and 2 by each group. So, Group A scored 10 in the second round. Group B scored a very high mark, 40 in the second round. Group C, 15. Group D, 5. So you can understand that the quiz champion is Group B, scoring 60 marks, the highest. Group B is represented. Group B represents Northeast Medical College. Then, okay, please have your seat. Then the runner-up is Group C, scoring 40. So, Sylhet Women's Medical College. The second runner-up is Group A, scored 30, Sylhet Osmani Medical College. And the fourth position was secured by Group D, scoring 17.5, Jalalabad Ragib Rabia Medical College. So I would like to request as a professor, Dr. A.K. Mahmudullah, and to say something and then start the prize distribution.
Assalamu alaikum. May I invite Professor M.A. Jolil Choudhury sir to give prize to the second runner-up group. Second runner-up, Sylhet MEG Osmani Medical College. College দিবে স্যার, এটা কলেজের, এটা এটা তো প্রপার্টি অফ দ্য কলেজ। কলেজ ওসমানী। Oh, now may I request Professor Shishir Ranjan Chakraborty, Principal Sylhet MEG Osmani Medical College, to give prize to the first runner-up, Sylhet Women's Medical College. Now the winner, I may request Professor Syed Atikul Haq, President of the Bangladesh Rheumatology Society, to give prize to the winner group. Northeast Medical College. Our fourth participant will also get prize, Jalalabad Ragib Medical College. Sir, please, sir. Sir, I request Syed Atikul Haq to give prize to them. Thank you very much. This is a very exciting session. I think you enjoyed well. Uh, I, I uh, um, may I request Professor Ismail Patwari sir to give prize crest to our moderator who did a very hard work and to give the quiz competition a successful one. Dr. ATM Tanvir Hassan certificate with appreciation certificate for conducting the quiz competition.
Good morning, learned audience and ladies and gentlemen. Now we are going to start our main scientific program of 15th Scientific Conference of Bangladesh Rheumatology Society. Today we have 5 sessions. Renowned rheumatologist of our country will deliver lecture on different aspects of rheumatic disorders. Now I like to request Professor Syed Atikul Haq, President Bangladesh Rheumatology Society, for his opening speech. Sir, please.
ডক্টর শামীম আমাকে ওপেনিং স্পিচ দেওয়ার জন্য অনেক ধন্যবাদ। আমি দেখছি আমাদের এখানে যারা রেজিস্টার্ড ডেলিগেট সব বেশিরভাগই এসে উপস্থিত হয়েছে এবং সবাই কুইজেও অংশ নিয়েছে, এবং এটাও ঠিক যে কুইজটা আসলেই যদিও আমরা মেইন সায়েন্টিফিক প্রোগ্রামের পার্ট হিসেবে ধরিনি, কিন্তু এটাতে সবাই খুব উৎসাহের সাথে অংশ নিয়েছে এই পার্টিসিপেন্টরা ছাড়াও, এবং আমার ধারণা যে প্রত্যেকেই অনেক উপকৃত হয়েছে। যাই হোক, আমাদের এখন এটা শুরু হবে মূল কনফারেন্স। আমি সবাইকে থাকার জন্য অনুরোধ করছি পুরো সময়টা। আমার দৃঢ় বিশ্বাস যে তোমাদের সবারই লেকচার থেকে অনেক উপকার হবে। আর আমি আমাদের এই সায়েন্টিফিক সেশনটার উদ্বোধন ঘোষণা করছি। ধন্যবাদ।
Dear participants, this is the most prestigious and important session of this conference, State of the Art Lecture. This lecture will be delivered by Professor Syed Atikul Haq. The chairpersons of the session is Professor M.A. Jolil Choudhury and Professor Shishir Chakraborty. This session will be moderated by Dr. Muhammad Shaista Ali Khan. may I request Professor M.A. Jolil Choudhury sir and Professor Shishir Ranjan Chakraborty sir to come to the dais and take their seat. Sir, please. And Dr. Mohammad Shaista Ali Khan, please come here.
Distinguished guests, respected teachers, and learned audience. Assalamu alaikum and very good morning to everybody. This is Dr. Mohammad Shaista Ali Khan, Associate Professor of Medicine. Welcome you all to the Art of the Lecture, the most prestigious, attractive, and precious lecture of this August gathering. Our beloved teacher of many teachers, Professor Syed Atikul Haq, is going to deliver his lecture on acute low back pain. Where do you stand? This session will be chaired by two eminent professors of the country, Professor M.A. Jolil Choudhury and Professor Shishir Ranjan Chakraborty sirs. I would like to request our honorable speaker and the chairpersons, please come up on the dais and have the chairs. Thank you very much. Ladies and gentlemen, I'm privileged and honored to be here to share a few words about the speaker, Professor Syed Atikul Haq. Professor Syed Atikul Haq, the Chief Consultant of the Green Life Center for Rheumatic Care and Research, is a retired professor of the Department of Rheumatology, Bangabandhu Sheikh Mujib Medical University. He was the pioneer who established the first rheumatology clinic of Bangladesh in 1991. The Department of Rheumatology was established at BSMU in 2012, and Professor Haq became its first chairman. He participated in forming the Bangladesh Rheumatology Society in 1997 and is now the president of this society. Professor Haq is the immediate past president of the Asia Pacific League for Association for Rheumatology, APLAR, and has served the APLAR as APLAR coordinator, vice president, and treasurer as well. He has been honored by APLAR and ACR with the APLAR Master and ACR Master Awards, respectively. Professor Haq's area of academic interest include epidemiology of rheumatic disorders, new osteoarthritis, and SLE. He has 171 publications, of which 114 are originals, and 65 are published in international peer-reviewed journals. He was awarded a gold medal by Bangladesh Academy of Science for his contribution to the advancement of science in this country. So, may I request our honorable speaker, Professor Syed Atikul Haq sir, to come up on the dais to deliver the lecture.
Mouse দিয়ে point.
Okay, respected chairpersons, dear moderator, and dear colleagues. I have been given the responsibility of talking on an issue that is very much uninteresting, boring. But even then, it's very common. So I think we have to learn details about this condition, that is acute low back pain. What do we mean by low back? Low back is the territory below the costal margin and above the inferior gluteal folds. And when do we call it acute? We call it acute when the onset is abrupt, it is moderate to severe in intensity, and the onset has occurred within previous 4 weeks. I shall present this under 4 major headings. One is the patterns of acute low back pain, approach to a patient, treatment, and finally conclusions. Patterns of low back pain. These patterns, I shall present under 5 scenarios each of the scenario presenting a particular pattern. The first one is a 65-year-old man presented with low back pain, progressively increasing since its onset before 3 weeks. The pain often awakens the patient at night. The patient fails to find out a comfortable position on bed. He also had anorexia and he lost 3 kg of weight during last 1 month. No symptoms from other systems and no pain elsewhere. On examination, there was some tenderness in the upper lumbar region and he had no other physical sign. His hemoglobin was 9.8 gram per DL, that is somewhat reduced, ESR 56, and other counts were normal. Other routine, including chest X-ray, ultrasonography, they were normal. And here you can see the X-ray, and you see the vertebral borders are visible everywhere in most of the vertebral bodies, but here this border is absent. And also we can see here the root of the pedicles. These are oval, elongated roots of the pedicles. They are present everywhere, but they are absent here. So the borders have been eroded or destroyed. We can say there is a lytic lesion. So this must be more likely to be a metastatic deposit. So I shall, speak something on the red flags, which should prompt a sense of emergency in our mind. One age more than 50 years, shorter duration, that is a few months, not in terms of years. Progressive pain, midnight pain, intractable pain, multi-segment pain, and pain relieved in no position. Then constitutional symptoms like anorexia, weight loss, fever, night sweats. Past history of cancer or radiotherapy, family history of cancers, focal signs including lymphadenopathy, thyroid nodule, breast nodule, abdominal lump, organomegaly. We often forget to palpate the testes. We have to remember testes, breast, these parts also need to be palpated. Sphincter dysfunction, bilateral or rapidly progressive neurodeficit. And under this heading, basically 3 major types of conditions come. One is spondylodiscitis or infections, maybe bacterial or fungal, or maybe metastatic deposits, or even primary tumor of the bones. And the third category, the lesion is not that dangerous, but it is pressing upon very vital structures. So now in this table I have tried to explain the differences between infection and metastasis. In infection, fever and night sweats are present, but in metastasis they are usually absent. Though we have to remember there are a few types of carcinoma like renal cell carcinoma, but they might present with fever and night sweats. Disc space is narrowed in infection, but disc space is intact in metastasis because metastasis occurs in the vascular parts, not in the avascular parts. Vertebral end plates are eroded in infection, but they remain intact in metastatic deposit. Lytic lesions are present in metastasis but absent in infection, and paravertebral soft tissue shadow that has been very nicely illustrated in the quiz session. And I am also repeating the same thing. Here we can see this space is narrowed. You can see this space is narrowed. The margins are irregular, and in the lateral view there is a soft tissue. This is prevertebral, this is not paravertebral, but we can call it paravertebral also. My second scenario is a 23-year-old man who presented with low back pain for 3 weeks. He had fluctuating low back pain for 7 years, and it is worst upon waking up. Wakes the patient at midnight and sometimes feels difficulty in turning sides when he is awake at late night. মানে যে কোনো কারণে যদি ঘুম ভাঙে তাহলে রোগী দেখেন যে তার পিঠটা একটা জড় পাথরের মতন বা কাঠের মতন হয়ে আছে, এপাশ ওপাশ ফিরতে খুব কষ্ট, স্টিফনেস। এটা একটা অত্যন্ত ইম্পর্টেন্ট পার্ট অফ হিস্ট্রি বলে আমি মনে করি। It subsides with activities and no red flag except nocturnal awakening. And সব যারা লো ব্যাক পেন নিয়ে আসবেন তাদেরকে আমি বলবো যারা এক্সট্রিমলি হারিড প্র্যাকটিশনার, যাদের 10-12 মিনিটের চেয়ে বেশি একজন রোগীকে সচরাচর দেওয়ার সময় হয় না, তাদেরকেও বলবো দুইটা রিউমাটোলজিক্যাল এক্সামিনেশন করতেই হবে। একটা হচ্ছে স্কুইজ টেস্ট, এইখানে এটা হচ্ছে মেটাকার্পাল স্কুইজ আর এটা মেটাটার্সাল স্কুইজ। স্কুইজ টেস্টে যদি টেন্ডারনেস পাওয়া যায় তাহলে আমাদের বুঝতে হবে এটা একটা সিস্টেমিক রিউম্যাটিক কন্ডিশন হতে পারে, সিস্টেমিক ইনফ্লামেটরি রিউম্যাটিক কন্ডিশন। আর এরপরেরটা হচ্ছে শোবার টেস্ট, এই যেখানে আমাদের পিঠটা আমরা যখন এইভাবে বেন্ড করি এটা আমাদের একটা ডোম লাইক স্ট্রাকচার নেয়, কিন্তু এখানে মনে হচ্ছে ওই সেই কাঠের তক্তা একসাথে সোজা হচ্ছে, বাঁকা হচ্ছে। এবার যাব, আচ্ছা কেস সিনারিও 2টাই আমি কন্টিনিউ করছি। ESR 95, hemoglobin 10.8, CRP 22, and here we can see, sclerosis, dense sclerosis on both iliac and sacral sides of both the sacroiliac joints. Now, let us discuss something about how to distinguish between pain of inflammatory origin and pain of mechanical origin. In inflammatory origin, the pain is actually relieved by activity, and it is, aggravated by rest, whether in mechanical, it is aggravated by activity and relieved by rest. This is very important point in the history in elaboration of pain. Diurnal, the inflammatory pain is worst in the morning and mechanical pain is worst in the afternoon. Morning stiffness is present, and in mechanical, morning stiffness is usually absent. Nocturnal pain is present here and nocturnal pain is absent. Of course, we have to remember that each of these points, individual points, has got their own fallacies. So we have to combine all the points. We have to ask all the points. Just by asking one question, we may be misguided, and we have to see the weight of evidences. Now, case scenario 3. A 38-year-old man presented with low back pain for 1 week with fluctuating severity, relieved by rest and aggravated by walking. So, is it inflammatory or mechanical? Anyone from the audience? Is this pain mechanical or inflammatory? What? Mechanical. Okay, thank you very much. Only 2 or 3 voices. The pain radiates to the right lower limb up to the posterior aspect of the right leg. Posterior aspect of the right leg and occasionally to the sole of the right foot. Eta কোন রুটের মনে হচ্ছে? Which dermatomy is affected? L4, L5, S1. S1, very good, S1. যদি L5 হয় তাহলে এদিক দিয়ে যাবে, lateral side of the leg. He had similar pain before 2 years that lasted for 2 weeks. No other focal or constitutional symptoms, no bladder bowel dysfunction. And nothing particular on general examination and examination of the chest, precordium and abdomen. Actually, we have to examine all these parts because we have to rule out, focal findings, focal signs. So we cannot, the patient has come with low back pain. So what is the need of examining chest, precordium and abdomen? We cannot think in this manner. We have to test, examine every part. Weakness of plantar flexion of the ankle, diminished ankle jerk and touch sensation in the sole and lateral aspect of the right foot. That is again this same S1. Routine lab parameters including acute phase reactants and X-ray, lumbosacral spine were unremarkable. Under this scenario, we usually don't do any MRI, but MRI of the patient was already done. He carried his MRI. And this is you can see here there is a disc herniation in between L5 and S1. Case scenario 4. A 50-year-old woman weighing 47 kg, that is underweight, with history of menopause before 8 years, that is, at the age of 42 years, you can say it is premature menopause, complains of low back pain with abrupt onset since a fall from the first step of a ladder during household chores on the day before. And it is partly relieved by rest and aggravated by activity. Is it mechanical or inflammatory? Okay, thank you very much. Doesn't have any major comorbidity or no other symptoms. On examination, there is a tender area on the upper part of the lumbar spine and no other physical sign. Urine, RE, CBC, CRP, SGPT and creatinine were normal. And this is the X-ray you can see here. This is, collapse. The height of this vertebra is shortened compared to the vertebral body above and below, and it is wedge shaped. So this is vertebral fracture or vertebral collapse. So what are the risk factors for vertebral compression fracture? Not risk factors for osteoporosis. In this slide I am showing only risk factors for vertebral compression fracture. One is major trauma like heavy road traffic accident, mild trauma with risk factors for osteoporosis, and other pathologies rendering the vertebrae fragile. So these are the causes of low trauma fracture osteoporosis. This may be postmenopausal, senile, juvenile, and secondary. Osteomalacia, rickets, chronic kidney disease, mineral bone disorder, which was previously called renal osteodystrophy. Of course, its spectrum is much wider than renal osteodystrophy. Neoplasms like metastatic deposits, myeloma, and bone tumors. Inherited disorders of bone structure and metabolism like osteogenesis imperfecta. Risk factors for osteoporosis. Actually, we classify the risk factors for osteoporosis into unmodifiable and modifiable, and we have to focus on the modifiable because with the unmodifiable we cannot do anything. We cannot change the gender, we cannot lower down the age like Gupi Bagha, Fire Elo. Low body weight, premature menopause, evidences of lifelong estrogen deficiency like irregular menses, scanty, oligomenorrhea, and parental hip fracture, lifelong inadequate calcium and vitamin D intake. These are unmodifiable. And what are the modifiable? Lack of exercises, we can increase it. Low calcium and vitamin D intake, smoking, excess alcohol intake, prolonged glucocorticoid intake, drugs. Particularly, I should repeat here, proton pump inhibitor and levothyroxine. These are two very widely abused medicines. There is a condition called sick euthyroid state, where the TSH level rises. It is temporary, it lasts for a few months, but most of the doctors often prescribe thyroxine and educate the patient to take this thyroxine lifelong. And I have come across 2 patients of fracture who had only this risk factor, like long-term intake of thyroxine. And PPI is also another, PPI, H2 blocker, this also, and diseases like thyrotoxicosis, hypogonadism. There are many other conditions, rheumatoid arthritis. Case scenario 5, a 38-year-old man presented with acute low back pain that started after bending trauma before about 18 hours. It is partially relieved by rest and aggravated by activity. That is, it is again that mechanical type. No major comorbidity, no red flag, no risk factors for osteoporosis, no abnormal sign on physical examination like root or cauda, and chest X-ray. That is complete blood counts, CRP, and X-ray, LS spine. Both views, these are normal. Actually, these investigations are not necessary also. So, this is called non-specific low back pain, and how do we define non-specific low back pain? Back pain in the absence of a specific underlying condition that can be reliably identified by history and examination. I repeat this, these I have shown 5 patterns, 4 patterns are specific, like red flag, then what is called inflammatory, then features of osteoporosis or fragility fracture, and with sciatica like radiation. These are the specific patterns. So what is left after exclusion, careful clinical exclusion of all these 4 patterns, it remains that is non-specific. The following are absent: red flags are absent, inflammatory nature is absent, compression fracture, features for like pattern of trauma, heavy trauma, risk for osteoporosis, these are absent, and symptoms and signs of root compression are also absent. And sadly, 95% of patients presenting with acute low back pain actually belong to this particular category, but we have to take history very meticulously, we have to examine the patient carefully to exclude those 5%, because failing to exclude the 5% will put us, the physicians as well as the patient, in danger. 70 to 90% improve within 7 weeks, and it is also called, that is why it is called simple low back pain. And the pathology is, exact pathology is not known, but it is thought that it must be muscle strain. Like, it may take place in the neck also, not ligamentous sprain, it is a strain. So, what are the risk factors for non-specific low back pain? Female gender, smoking, obesity, physically strenuous work at one hand, and sedentary work on the other. It means Madhya Panthai, Sharbottam Pantha. Psychologically strenuous work, low educational attainment, job dissatisfaction, somatization disorder, anxiety and depression. Now I come to my, that is called third part. Second part, approach to a patient with low back pain. Actually, here my main lecture starts. Steps of evaluation, history, examination and laboratory evaluation, same as most symptoms. And carefully, what is the main basic theme of this history taking and examination? We have to carefully exclude red flags, features of inflammation, compression fracture like major trauma, risk factors for osteoporosis, and trauma description and root compression. We have to carefully exclude these 4 things. So in the history, detailed characteristic of the pain, constitutional symptoms like fever, weight loss, and also focal symptoms like cough, alteration in the bowel habit, abdominal pain, all these things. So physical examination, evaluation for malignancy. This is very much important. Clinical evaluation for malignancy. That is, we have to palpate thyroid, lymph node, breast, prostate, squeeze test, inspection of back and posture, palpation of the spine, a gibbous may be felt or a tender area, range of motion, particularly shoulders, straight leg raising test, and neurological assessment of L4, 5 and S1. I don't ask you to do thorough neurological examination, but at least these things we have to see. So we have to be very cautious that there is no investigation, however costly investigation the patient can afford, there is no investigation which can supplant information obtainable from history and examination. So what should be our approach to imaging? Up to 90% of patients with back pain alone improve rapidly. Imaging studies are infrequently needed. American College of Physicians advises that diagnostic imaging is indicated for patients with low back pain only if they have severe or progressive neurodeficit, signs and symptoms that suggest a serious underlying condition, that is red flags, and when the pain doesn't decrease in 4 weeks. These are the conditions for imaging. And what should be our choice of imaging? If the pain is inflammatory in nature, we have to do X-ray of the SI joints. If the pain is suggestive of vertebral compression fracture, dorsolumbar spine, lateral view. If red flags are present, we have to do MRI or CT guided FNAC or core biopsy. Biopsy is not imaging, but CT guided FNAC or core biopsy has to be done under CT. Basically, what I often do to save the money of the patients, first I do a plain X-ray, and if there is a light lesion, I go directly to CT guided FNAC or core biopsy, because the lesion is already visible at plain X-ray. But if plain X-ray doesn't reveal any relevant pathology, then we have to do MRI and then again CT guided FNAC. It becomes more expensive. In lumbago sciatica, imaging is unnecessary unless it is refractory, and for non-specific low back pain, if we are confident that we have excluded other 4 patterns and this is non-specific, no imaging is necessary. And laboratory we can do, for those in the gray area, not for all, complete blood counts including ESR, CRP and imaging. Now let's move to treatment of acute low back pain, the third section. The treatment, what is the goal of treatment? The short time symptomatic relief. because they will subside automatically. We don't need to do anything other than symptomatic relief. And what are the types of treatment? Pharmacological and non-pharmacological. Pharmacological first line is NSAID, naproxen 250 to 500 milligram twice daily, or ibuprofen 400 milligram to 600 milligram 4 times daily. Second line for those refractory to the monotherapy, and in non-benzodiazepine muscle relaxant, not benzodiazepine. You have to remember carefully, because in our country, lexotanil, rivotril, these are most commonly prescribed muscle relaxants in acute low back pain. They should be strictly avoided. Non-benzodiazepine muscle relaxant may be combined with the NSAID like baclofen, tizanidine, cyclobenzapine, and carisoprodol. All are available in Bangladesh now. A third line is NSAID plus paracetamol, who cannot tolerate muscle relaxants, because these muscle relaxants are, their side effects are very common. The drugs that should not be used. Paracetamol alone should not be used, but it is not that effective. Benzodiazepines, induction of tolerance. Opioids, abuse potential. Tramadol, adverse effects. Anti-epileptics, antidepressants, no place. Topical agents, systemic glucocorticoids, herbal therapy should not be given. Now let's move to non-pharmacological. And actually, these are actually, here I have started with, the treatment options that should not be prescribed. Because, in the non-pharmacological category, you will see these are the options that are often suggested. Most often, cold, massage. Heat is beneficial, but cold is not. Massage, traction, lumbar support, corsets and braces, very frequently advised, and they are harmful. And mattress recommendations, yoga, chiropractic treatment. There is no evidence of benefit. Bed rest is rather harmful. Patients who are treated with bed rest have more pain and slower recovery than ambulatory patients. Unproven non-surgical interventions like paraspinal injection, intradiscal injection of glucocorticoid, anti-tumor necrosis factor alpha, facet joint injection, prolotherapy and PRP, and botulinum toxin injection. These are all bogus. Non-pharmacological evidence-based treatment. So we are coming to what is evidence-based from non-pharmacological. Number one is superficial hit. And number two, patient education, very important. We have to explain the benign nature and good prognosis of the condition, minimal value of diagnostic testing, and advice to stay active. This is very important, and continued activity and quick return to work. For prevention of recurrence, we should suggest weight loss, smoking cessation, and avoidance of other risk factors, and ergonomic correction of workplace. For patients with occupational low back pain, they also present with, relapses and remissions, and they can present with acute low back pain. Exercise is not effective for acute low back pain, but exercise is beneficial for patient, for prevention of progression to chronicity, and in those in whom there are risk factors for progression to chronicity. So, what are the predictors of chronicity? Functional impairment, maladaptive pain coping behavior, মানে যারা ব্যথায় যন্ত্রণায় কেঁদে ওঠেন, গঙ্গান, কাতরান, যারা দৃষ্টি আকর্ষণের চেষ্টা করেন, যারা ব্যথা কেমন জিজ্ঞেস করলে একটা কথার মধ্যে ঢেউ তুলে সেই কি জানে সমুদ্রে ঝড়ের মতন করে বলবেন স্যার প্রচন্ড ব্যথা, এগুলি হচ্ছে এটার জন্য কারো দোষ নাই, কিন্তু এটার জন্য উই শুড নট অ্যাকিউজ দ্য পেশেন্টস, বিকজ ওই অ্যাবসেন্স অফ কোপিং and catastrophizing, there are genes for these conditions also. So, presence of psychiatric comorbidities and non-organic signs. What are the non-organic signs? These non-organic signs have been devised by Waddell. He is a very world famous, renowned, back pain expert. Overreaction during physical examination, superficial or widespread pain, then overreaction, কখনো কখনো আমরা বলি startle, exaggerated startle response. ডাক দিলাম চমকায় উঠলেন। Inconsistent supine and seated straight leg raise test, তারপরে আনএক্সপ্লেইনেবল নিউরোলজিক্যাল ডেফিসিট, কখনো কখনো কেউ কেউ বলেন হ্যাঁ ব্যথাটা আমার একটু রেডিয়েট করে বা এর ল্যাটারাল সাইডে যাচ্ছে, অথচ আমরা এক্সামিন করতে গিয়ে দেখি যে S1-এ সেন্সরি ইম্পেয়ারমেন্ট, আবার অন্যদিকে একটু আছে। এগুলো তো কিন্তু সাবজেক্টিভ, এই যে আমরা সেন্সেশন দেখি দিস ইজ নট এন্টায়ারলি অবজেক্টিভ, এখানে কিছু সাবজেক্টিভিজম আছে। দ্য পেইন অন সাইমুলেটেড অ্যাক্সিয়াল লোড, মানে মাথার উপর চাপ দিলে ব্যথা বেড়ে যায়, এটা হচ্ছে, এগুলি হচ্ছে নন অর্গানিক সাইন্স। সো নাও আই কাম টু দ্য কনক্লুশনস। Acute low back pain is one of the clinical conditions with highest prevalence rates. Red flags, inflammatory nature, fracture propensity, and neurological complications must be ruled out. And the treatment entails education, NSAID, and continued activity are the cornerstones of treatment. So, I thank you all. This is a suggestion with exercise. Thank you so much.
Touching pros and cons of such a big topic within limited time frame is an art, and this art is only possible because of our beloved professor Syed Atikul Haq sir. Thank you very very much sir. Now may I request our honorable chairpersons. Is there any questions? So may I request one of our chairpersons, astute clinicians, beloved professors, and principal, Professor Shishir Ranjan Chakraborty sir, to deliver few words.
Thank you very much. First of all, I like to my heartfelt thanks to Bangladesh Society of Bangladesh Rheumatology Society and its officials to invite me and give me the opportunity to chair the session. But it's very embarrassing for me because in this session it was undesirable for me because Syed Atikul Haq is such a personality, such teacher. He was a teacher of Sylhet Usmani Medical College when we were we are student of this college, and we learned many things from BSMMU from him, especially approach, rational approach, and specific diagnosis and evidence-based management. These are he follows very nicely, strictly, and this was our we are from Sylhet. We went to BSMMU for our FCPS Part 2 training, and we actually evidence-based medicine. We came to know this term from Professor Syed Atikul Haq, and many things from approach, and very nicely. It's a very good learning session. We have learned many things. I hope our many mid-level doctors here, they have learned many things, and they will be very much practical with from this session. They misuse of investigation is very common. Like a simple low back pain, before seeing the patient, before examining patient, we are writing MRI of the lumbosacral spine, and after getting a very small bulging in the or very small compression in a nerve root, someone is advising him or her to go for operation, otherwise our leg may be paralyzed or so. This is question, and they are going to, among that I am thinking that they are we are practicing this is like a surgery in low back pain. And so who will treat low back pain patient? Is going to pain specialist, going to physical medicine specialist, going to internist, going to neurosurgeons. In Sylhet, a large group of patients of low back pain is a common community problem. I think our OPD patient, around 30% patient is OPD is from pain. Among pain, 20% patient is low back pain. So a very large group of patient comes to our OPD in different OPD with low back pain. And majority patient is does not got that is appropriate treatment, they are malpractice. So we should be. Here is our many young doctors. They will be very rational. They will keep this lecture. They will follow this lecture, and they will improve their quality and clinical. There is nothing more than clinical. Clinical decision is a history taking an examination. Nothing is superior to that. Again, I like to thanks Professor Syed Atikul Haq sir for giving a very nice learning lecture in this year. And again, I thanks Bangladesh Rheumatology Society for giving me the opportunity. Thank you very much.
Thank you, sir. I would like to request our guardian, our teacher, and eminent professor of the country, Professor M.A. Chaudhary sir, to utter some cut-edging comments here. Thank you.
Thank you. আমার শায়েস্তা আলী খান নোমান হঠাৎ করে তোমার নাম শুনে আমার শায়েস্তা খান আমার কথা মনে পড়লো আর কি যাও it's a great privilege for me to preside over the session of an art lecture given by Professor Atik. Professor Atik need no introduction. First of all, he was in Sylhet Medical College for a brief period, so he is known to Sylhetwasi. He was my chairman during my job in BSMU. He was an internist. I know him as an internist, good internist, not as a rheumatologist. Because his basic degree and basic qualification, basic starting is from internist. And today's topic seems to be very light because we are accustomed that art lecture should be a very artistic way. But the society has chosen such a topic which is very common and which is problematic for most of the specialties. আমার তো এখানে এমন কেউ নাই একটু বয়স যাদের আছে লোবেক পাইনে এমন মানুষ খুব কমে আছে আর আমার তো আছি লোবেক পাইন সম্বন্ধে আমার কিন্তু পড়াশোনা অনেক বেশি হয়ে গেছে কারণ আমি জানি যে লোবেক পাইন কারণ অনেক জায়গায় গেছি তো সেটা দেখলাম যে নিজে পড়ে ফেলে ভালো লোবেক পাইনটা এই জন্য আতিকরে বলছি যে লোবেক পাইনটা আমাকে পাঠিয়ে দেওয়ার জন্য এবং ছোট্ট গল্প পড়তে রবীন্দ্রনাথের যত ভালো লাগে বড় উপন্যাস পড়তে কিন্তু অত ভালো লাগে না ছোট কথা গোছাই বলতে পারা সুন্দরভাবে বলতে পারা এটা কিন্তু বিরাট আর্টের ব্যাপার এবং সেইভাবে কিন্তু দিস ইজ আর্ট লেকচার কারণ সে ছোট্ট জিনিসটাকে কমন জিনিসটাকে সে আর্টিস্টিক হয়তো বলছে ইন এ সেন্স দিস এ স্টেট অফ আর্ট লেকচার নো ডাউট এবং সে আমি যখন এটা কেউ মনে করেন না যখন কেউ লেকচার দেয় আমি যে হোয়াট দ্য ডিফারেন্স বিটুইন ফিফথ ইয়ার ক্লাস লেকচার আর দিস লেকচার আমরা আমিও অনেক সময় করি কি একটা লেকচার দিয়ে মনে হয় যে ফিফথ ইয়ারের ক্লাস নিচ্ছি আমি অথবা পোস্ট গ্রাজুয়েট ক্লাস নিচ্ছি কিন্তু এটা ডিফারেন্ট এখানে অনেক লার্নিং আছে শুধু যে টপিক শিখবেন তা না কিন্তু লেকচার কীভাবে বানাইতে হয় একটা স্লাইডে কটা সেন্টেন্স থাকতে হয় এইটাও কিন্তু একটা শেখার জিনিস এখানে অনেক কিছু শেখার আছে ওনার থেকে এবং কীভাবে লেকচার দিতে হয় নট যে একটা ইটোলজি প্যাথোজেনেসিস তারপর কজ হেডিং দিয়ে কিছু লেকচার বানিয়ে নিয়ে আসলাম বইয়ের থেকে আপডেট থেকে তা না কিন্তু ওনার লেকচারটা ছিল অনেকটা প্র্যাকটিক্যাল ওরিয়েন্টেড যেমন সিনারি বেস দিয়া এটাকে আমার জন্য খুব লুব্রিকেটিং একটা টপিক দিয়েছে এরকম সন্দেহ নেই তো আর্ট অফ লেকচার হবে কোনো কমেন্ট করার নিয়ম নাই করা উচিত না কারণ আর্ট অফ লেকচার যিনি দেন উনি এমন পজিশন থেকে দেন তার উপরে কোনো কমেন্ট করার আমার মনে কেউ করা উচিত নয় কিন্তু যেহেতু টপিকটা কমন আপনি নিজেও লোক পেয়ে রোগী দু একটা কথা না বলে পারছি না ব্যাগিং এক্সকিউজ ফ্রম প্রফেসর আতিক নাইট সোয়েট শব্দগুলা অহরহ ব্যবহার করা ঠিক না কারণ গরমের দিনে আপনি ঘরে ঘুমাইলেন ফ্যান নাই কারেন্ট চলে গেছে আইসা করে স্যার আমার তো নাইট চলেছে কালকে রাত্রে তা আপনি বলেন যে আপনার তো মানে ব্যবহার হয়েছে এটাকে একটু খেয়াল করতে হবে আর কি আর আমি অবশ্য হাসি প্রফেসর আতিকে নিয়ে স্কুইজটা জন করে আমি স্কুইজটা কে কত বড় জোরে চাপ দিই বা তার ডিপেন্ড করে স্কুইজটার এটা একটা ফর্মুলা আছে বোধ হয় সেটা বলে নেই তাহলে কিন্তু জোরে চাপলে স্কুইজটা পজিটিভ হবে আবার হালকা চাপলে স্কুইজটা পজিটিভ হবে না এগুলো একটু খেয়াল করেন ভালো তারপর থাইরয়েড সম্বন্ধে বলছে এটা খুব ফ্যাশনেবল জিনিস এগুলো এই কথা আমার না থাইরয়েড হয়েছে এটা খুব প্রাউড ফিল করে সে বলছে না অনেক কিছুই বলছে তারপর এবং প্রফেসর আতিক অনেক ভালোভাবে বলছে উই মেড দ্য সিম্পল লো ওয়েভ ইন এ কমপ্লিকেটেড ওয়ে লোকেদেরকে আমরা করে বুঝিয়ে দিই যে দেখেন এইখানে আপনাদের ফাঁক হয়ে গেছে একটু সুতরাং এটা ছিল সিম্পল রূপে, প্রফেসর আতিক বলছে, এবং উই মেড দ্য ফিজিশিয়ান ইট কমপ্লিকেটেড। বিভিন্ন ইনভেস্টিগেটর বিভিন্ন বুঝাইয়া কাউন্সিলিং ওভার কাউন্সিলিং করা, আর যদি একবার সার্জারি করতে পারে তো ভোগান্তি শুরুই হলো আর কি। কমপ্লিকেটেড মানে মোর কমপ্লিকেটেড, মোর কমপ্লেক্স হয়ে গেল এটাকে। দেখ আমরা সব সাবধান থাকবো আমরা। এবং আর জিনিস প্রফেসর আতিক বলছে খুব প্রয়োজনযোগ্য কথাবার্তা, এটা আমাদের হাসিশনে আছে যে রোগী আমাদের একটা কথার প্রশ্নের উত্তর অ্যান্সার গিভেন বাই দ্য পেশেন্ট ইজ মোর দ্যান এ ভ্যালুয়েবল সফিস্টিকেটেড ইনভেস্টিগেশন। এই কথাটা প্রফেসর আতিক বলছে, এবং এটা সব ক্ষেত্রে প্রযোজ্য, এবং লো ব্যাক পেনের রোগীর জন্য এটা প্রযোজ্য। এই কথাটা প্রফেসর আতিক ভালো করে বলছে। কোর্সের ব্যাপারে তো এটাও তো একটা মিস ইউজ হয়, এটা আতিক বলছে, তাও সময়ের অভাবে তাকে স্কুইজ টেস্ট করা হয়েছে, ওকে বলা হয়েছে অল্প সময় বলবেন, এই জন্য ইম্পর্টেন্ট জিনিসগুলো বলার সুযোগ পায়নি কোর্সের। সাবিনা আছে কিনা এখানে, চলে গেছে বোধ হয় ইয়েকে দেখতে, শাইনকে দেখতে। আমার লোকজন ছিল, তো আমি কিনা বলে কোর্সের ব্যবহার করতাম। একদিন বিএসসির মধ্যে আমি কোর্সের পরে বসে আসি, তো সাবিনা আমাকে দেখছে, তখন সে আরো জুনিয়র। স্যার আপনি তো পড়ছেন কেন? আমি কেন আমার তো লোক পেন, স্যার খোলেন। সে আমার ওই সময় খোলাইলো, খোলাই আমাকে বললো স্যার এটা আপনি জীবনে পড়বেন না। এবং কেন পড়বেন, তখন আমার নলেজ কম ছিল, সে বুঝিয়ে বললো। এবং এরপরে থেকে আমি কোর্সে পড়িও না, কাউকে পড়তেও দিই না, কিন্তু রুগীরা কোর্সে সবাই পড়ে। এটা পড়লে মনে হয় যে একটা কিছু করছে আর কি, কিন্তু কত ক্ষতি করে, পুরো ক্ষতিটা কেন করে বুঝে নেই। আমি পরীক্ষার সময় প্রায় একটা কোশ্চেন করি, এখন তো সুযোগ নেই, এখন আমাকে এক্সামিনে বানাবে না, যে হোয়াট ইজ দ্য অ্যাডভান্টেজ অফ এক্সারসাইজ, এক্সারসাইজ করলে কী লাভ হয়। আমি জানি না, কেউ যারা একটু অ্যাডভান্স পড়াশোনা তারা জানে, কিন্তু অনেকে জানে না এক্সারসাইজ করলে হাউ ইট এফেক্টস। ব্যায়াম করলে কী লাভ, ব্যায়াম করলে ব্যথাটা কীভাবে কমে, ব্যায়াম কেন আমরা দিই, এটা কিন্তু অনেকে জানে না। কিন্তু যারা জানে তারা জানুক, কিন্তু যারা জানে না আমাদের ওই জিনিসটা জানা উচিত। এক্সারসাইজ কী কী এক্সারসাইজ সেটা আমরা জানি অনেকে, পাও তোলা, পা নামানো, কোমর পাকা করা, এগুলো আমরা জানি, কিন্তু এটা কেমনে কাজটা করে, এটা প্যাথোফিজিওলজি কি, এটা কিন্তু আমাদের অনেক সবাই জানা উচিত এটা। তো আর আমি মনে হয় এই আর্ট অফ ভ্যাকসিন নিয়ে বেশি কিছু বলা ঠিক না, আমাকে এখানে আসতে বলাতে সিলেটে আমি অনেকবারে আসছি, শুধু মেডিসিন সোসাইটি অনুষ্ঠানে আসিনি, শুধু এটা আসার জন্য, কারণ এটা আসতে আমি বাধ্য ছিলাম, যেহেতু প্রফেসর আতিকের সাথে আমি বহুত কাজ করছি, এবং রিমোটলি যারা ছিল তারা সবাই বেসিক্যালি মেডিসিন লোক। তো এই জন্য আসছি, যদিও মেডিসিন সোসাইটি আমার আসা উচিত ছিল, কিন্তু দুইটা একসাথে আসা সম্ভব ছিল। আবার সেই লো ব্যাক পেনের ব্যবস্থা করা আছে। থ্যাংক ইউ এভরিবডি, থ্যাংক ইউ সো মাচ।
থ্যাংক ইউ স্যার, অশেষ ধন্যবাদ। With great sense of humor, with great philosophy, and having the authority to speak on this topic, Professor M.A. Jalil Chaudhary sir has nicely delivered his comments. This is the time to deliver the memento, and I am requesting our honorable chairpersons to deliver the memento, to hand over the memento to our speaker, Professor Syed Atikul Haq sir. Thank you, sir. I would like to request our distinguished guest, Professor M.A. Ahbab sir. Sir, there are parts for you. Sir. I am requesting our honorable chairpersons to stay in the dais and requesting our distinguished guest, Professor M.A. Ahbab sir, to hand over the certificate to our honorable chairpersons.
It's a memory.
Thank you very much, sir.
May I request Professor Ahab sir to give certificate to our very renowned Shahist Ali Khan, associate professor, and he did a very good moderation. Thank you very much. Dear audience, this is the time for tea break, and after tea break, please come as soon as possible to that auditorium. The time is 30 minutes only. There is another announcement. Those who registered outside Dhaka, please collect your kits from Incepta stall. And there will be an attractive raffle draw at before lunch. Dear audience, please come in time.